May I invite for the next session, Dr. Joseph Papashan, and to moderate Dr. M. Saifuddin. So Dr. Papashan is a consultant in endocrinology and metabolism, who is a research lead as well in postgraduate training lead for medicine and a professor and a clinical chair. And he is currently affiliated to the Lancashire Teaching NHS Trust in the Manchester Metropolitan University, the University of Manchester Medical College as well. And he had been an editor, a chief editor, as well as in the editorial boards of multiple renowned journals, such as Elsevier, journals such as Endocrine Hypertension, and World Journal of Diabetes, Frontier Clinical Diabetes, touch reviews of endocrinology and current drug safety, and also editorial board member for JCEM case reports. And he has had major achievements, multiple awards as well. There are numerous publications under Dr. Papashan's name. And to moderate the session, I would also like to kindly invite Dr. M. Saifuddin. And Dr. Saifuddin is presently an associate professor in endocrinology, affiliated to Dhaka Medical College in Bangladesh, and he has had multiple scientific as well as research. He is the scientific and research secretary in the Bangladesh Society for Endocrinology, Bangladesh Endocrine Society (BES), and there are multiple publications under his name as well. The research interest of Dr. Saifuddin in adrenal diseases, thyroid, as well as osteoporosis. May I invite Dr. Papashan and Dr. Saifuddin to take over the next session, which is on ideation for innovative research. May you take over, please.
Thanks a lot, Dr. Dakshi, for your nice introduction. And also it's nice to have Dr. Joseph Papashan. Now I request thank you so much. Now I request Joseph Papashan to talk on ideation of innovative research. After your presentation, we'll ask some questions for you. So please go ahead.
Nice to meet you all this evening. I am Papashan Joseph from UK. Greetings from the UK. My topic today is prediabetes ideation for innovative research. I'll give a quick snapshot of the global scenario on prediabetes. After which we can have a discussion with my colleague, Dr. Saifuddin. Thank you for having me invited to this evening meeting. This is my competing interest statement. Already we have had some discussion about the global scenario, about the statistics. If you look at USA has more than 1/3 of its population with prediabetes, of whom 80% are unaware of the situation. UK may have the similar prevalence, but we use the NICE criteria with HbA1c more than 42 as the cutoff, and fasting sugars more than, in Indian money, it's 110 milligrams per deciliter. We have about 1/5 of the population currently affected with prediabetes. Europe has similar prevalence, about 27%, and as mentioned previously, India has about 25% prevalence according to the ADA criteria. This is based on a previous study using the WHO criteria, and you can see the individual cutoffs for different states in India. The at-risk population, we have to consider everyone with overweight and obesity having prediabetes. Age cutoff is more than 40 years as per the NICE criteria, and anyone more than 25 if they are non-white. But the ADA recently has changed the criteria to more than 35 years for any population. If there's a sibling or a family member with type 2 diabetes, the risk is 2 to 6 times higher. Again, gestational diabetes mellitus with higher prevalence. If we look at the odds ratio for gestational diabetes mellitus to develop prediabetes, it's 3.7 times higher. Various ethnic groups, especially when they migrate to developed countries such as UK or Europe or USA, they have much higher prevalence of prediabetes. This is an important research question which needs to be further explored, probably because of lower metabolism, basal metabolism, when we move to these countries from a very warm, humid environment where we sweat regularly, whereas when we come to a cold weather, it results in reduced cutaneous blood flow, and possibly the metabolic rate is, in my calculation, around 30% less than the native population in India or the tropics. We know that there are a lot of modifiable risk factors such as body weight management, dietary changes, physical activity, stress to some extent, depending on how you design your daily life, sleep pattern, and other comorbidities such as dyslipidemia and hypertension, which may improve the risk of prediabetes also. This is a data from Brazil, a recent study published from Brazil, but we don't have enough data from the global different regions. The risk of type 2 diabetes in patients with prediabetes is around 40% at a follow-up of 7.4 years. So we should have more data from everywhere in the world. Children, unfortunately, there's a growing pandemic of childhood obesity across the globe, even in developing countries such as Asia-Pacific region. So we have to screen all the high-risk individuals as per the standard international criteria of the International Society for Pediatric as well as Adolescent Diabetes and UK Preventive and Supportive Task Forces 2022 updates. So the definitions almost similar to those in adults, and we don't have enough data from the pediatric population about the prevalence of prediabetes and even obesity. So we'll have to have more data on these areas. This is a data from Balochistan published recently. If you look at the abdominal adiposity, it's quite high. I was surprised to see these figures in the recent publication. And you can see the prevalence of prediabetes at about 1/3 of population is affected, even with the WHO criteria. If you take the ADA criteria, it will be much higher. The screening strategies, adults with BMI more than 25, if that's a Caucasian, and if it is more than 23, it's a non-white population in this country and many of the developed countries. Anyone with prediabetes should be regularly screened for incident diabetes, and those with GDM at least should be screened every 3 years, and age more than 35 years as per the most recent ADA update. All those with HIV should be screened regularly because of the high risk in relation to the treatment as well as the metabolic syndrome in such patients. Targets, we don't have clear target set, but we could probably consider these figures as targets for management of these patients as per the current ADA update. We have various dietary principles in managing patients with pre-diabetes. We all know that a low carbohydrate, calorie restricted, hypocaloric diet should help, especially when coupled with other lifestyle interventions such as regular exercise to improve pre-diabetes and incident diabetes in future. But again, we should have more data on this. We have to be mindful about the exercise interventions. 150 minutes of moderate intensity exercise, such as brisk walking, and 2 sessions of strength training as per the current standard international guidance will help us to lose 1,100 calories a week. However, we have to be mindful, unless we couple this with dietary interventions, simply 2 cupfuls of sweetened beverages can neutralize this benefit. Still, exercise may be important, right? We just had a discussion about the pharmacotherapeutic interventions. We know that metformin is useful in various subgroups, especially but we need to have more data on this. GLP-1 agonists, my speaker was mentioning about the odds ratio for improvement. But again, we don't have enough data on prediabetes exclusively, except in patients with obesity and all. SGLT2 inhibitors also mentioned just now, but we should have more data on prediabetes. Various medical interventions, of course, different categories of medications should help, and the number needed to treat is possibly, especially when we combine with lifestyle interventions, is 25. That's probably better than the use of statins for prevention of cardiovascular disease. So we have to consider medications in appropriate settings. Of course, bariatric surgery and bariatric procedures are important for various bariatric interventions, including endobariatric treatment, are very important for management of severe obesity, which invariably results in reversal of prediabetes and many of the comorbidities, as you can see from this slide. But again, we should have more data on exclusive management of pre-diabetes. As we all know, those patients with higher risk should be managed appropriately with various medications, including statins, severe insulin resistance and a previous stroke or cardiovascular disease. We have to consider pioglitazone, metabolic associated fatty liver disease, and you have to screen regularly for steatohepatitis and fibrosis, heart failure with SGLT2 inhibitors, and a severe obesity, bariatric procedures, and sleep apnea should be appropriately managed. But again, we should have more data on these domains of standard of care for patients with prediabetes. We all know that intense lifestyle interventions is currently the best management option for prediabetes. But as we have seen from the Look Ahead trial, the sustainability is quite poor. Even with the reversal of the initial metabolic insult, most of these patients will revert to have problems in future. So a regular ongoing care for such patients with intense lifestyle interventions are important to modify the behavioral pattern of patients to ensure that they are appropriately managed. A previous work has shown that regular stimulation of the adipose tissue to brown the fat, the white adipose tissue to brown adipose tissue, may improve metabolic health and weight loss. If you stimulate 1 teaspoonful of white fat to make it brown, it may help to lose about 3.5 kilograms in a year time. So, but these are all investigations still going. We have to be mindful about the cost effectiveness of various interventions. We are not clear about these things, especially the newer pharmacotherapy like SGLT2 inhibitors and semaglutide, but in an appropriately tailored clinical settings, these interventions should definitely help the patient. Concluding my initial presentation, as in the current ADA recommendation for type 2 diabetes, we have to assess the patient with the pre-diabetes to know about the characteristics, consider specific factors that may impact the treatment, utilize a shared decision-making in liaison with the patient, agree upon the management plan, implement it, provide ongoing support, and revisit the plan periodically to improve or augment the plan. And it should be in a vicious circle to ensure that our patients are getting the best care. Thank you. I'm concluding the initial remarks about this, and I'm happy to have a discussion now.
Thanks, dear Joseph, for your outstanding presentation regarding ideation of innovative research. So I have a few questions for you. You know, different kinds of diet are popular in managing diabetes, pre-diabetes, and obesity all over the country. So what are the problems with various diet in managing pre-diabetes? What is your thinking?
Right. As I mentioned, the sustainability of many of the interventions can be a real issue. For example, I had a close friend whose wife had been suffering with type 2 diabetes. She used to get hidradenitis suppurativa in her axilla as well as groin regularly, and she has been struggling too much. She wanted to treat it properly, and she was never managing her diabetes properly. One of the physicians suggested that, okay, if you go on to a very low calorie diet, which he prescribed, you can even stop your medications. She did. She succeeded initially. She lost around 12 kilograms body weight in 6 months period, and she could stop all the medications. Diabetes came into remission. But unfortunately, as we already mentioned, it could be a behavioral problem. Naturally, gradually, she started eating a little amount of additional sugary items. And 3-4 years later, she became frankly diabetic, and she's currently on insulin. So this is one of the major issues. A sustained effort from the patient and a regular motivation from the clinician. That's very important. Various dietary interventions. One of my collaborators from India recently contacted me. He's a retired professor from Sri Tirunal Institute. He told me that he lost 9 kilograms body weight with time-restricted eating behavior. But he was asking me, what is the long-term effect of it? I said, sir, we don't know. These are all newer trial-based ideas. We don't know the long-term implications of this kind of special diet. High-protein diet, for example. Several of us take high-protein diet, or we probably ask patients to take high-protein diet, but we don't know the implications in terms of high uric acid, hyperuricemia, and possibly metabolic stress from that, or oxidant stress from that. So these are the problems with various dietary items. So we don't know the long-term outcomes of this without having adequate data.
Thank you so much, sir. Different kind of eating pattern like intermittent fasting or time-restricted eating pattern are also becoming popular in people with obesity, diabetes, and prediabetes. So what is your thinking regarding the role of this intermittent fasting or time-restricted eating pattern in managing prediabetes?
Right. I'll come to a couple of slides.
Yes.
Trying to, yeah, that's your question. So basically, a time-restricted eating pattern is eating for a window period of about 10 hours a day, or maybe maximum 12 hours a day. So we should have a 12-hour overnight fasting, or probably more. And ideally, it is a 10-hour fasting. So our glycogen storage, the stored energy in the liver, is lasting only up to 12 hours. The glycogen stores will get depleted by 12 hours of overnight fasting, and then the fat starts mobilizing at around 12 to 14 hours period. So if we do a 12-hour, 10-hour or less amount of eating pattern, it will be probably better for our circadian rhythms as well. So if you do full overnight fasting plus an additional couple of hours, it will probably synchronize with your circadian rhythm. That will help to protect from many of the metabolic disorders. And if we desynchronize our biological clock system, it can be associated with various metabolic disorders, including prediabetes, obesity, and type 2 diabetes. So that's the implication. Intermittent fasting, basically, similar mechanism of action. So you have a longer period of fasting or a total day of fasting. Different types of intermittent fasting schedules are there. So that will, again, help to mobilize the eutropic fat, which may help the situation. So that's why we have to consider this kind of interventions in many individuals we treat on a daily basis.
Thank you, sir. Some newer medication we are using from diabetes and obesity. Is there any role of such kind of medication in prediabetes?
Right. I will come to another slide with that. So basically, many of these newer medications, we don't have enough data about their use in managing patients with prediabetes. But if you look at the data, the semaglutide data has been published in 2022 in the New England Journal, you can see more than 10% of weight loss was achieved by 54% of patients, and I would assume all these patients should have reversal of prediabetes. If you look at the percentage of people who lost more than 20% of weight, about 35% of patients on semaglutide at higher supraphysiological dose lost more than 20%. That's at par with probably bariatric surgeries. All these patients will have reversal of prediabetes, but we don't have enough data, so we should have more data. Looking at the tirzepatide data, if you look at the amount of weight loss, it's at par with bariatric surgery in significant chunk of patients. Around 40% of patients on highest dose of tirzepatide had weight loss more than 25%, implying that all these patients should have prediabetes reversal. But again, we have only limited data, so we'll have to be mindful about that.
Thank you, sir. Metabolic associated fatty liver disease have become increasingly common nowadays. What is your thoughts regarding the management of prediabetes with MAFLD?
So we have recently edited a journal issue on metabolic associated fatty liver disease, and we had a lot of good papers from different regions of the world. And we have recently updated one review on this topic. So if you look at the interlink between diabetes and metabolic associated fatty liver disease, they are very closely connected. They are like twins in metabolic disorder. In fact, hepatic insulin resistance is the prime reason for metabolic associated fatty liver disease. Again, generalized insulin resistance will cause pancreatic beta cell dysfunction, and both these are interconnected in a vicious circle. So fatty liver will perpetuate the diabetes progression or prediabetes progression, and this metabolic dysfunction will invariably worsen the fatty liver disease. So they are very closely interconnected. So we have to manage fatty liver properly before we treat a patient with the prediabetes. So it's just like treating each conditions because of the commonality of the pathophysiology. And if you look at that statistics, Professor Kalra has sent data, and it says that about 40% of people with prediabetes may have fatty liver disease in them. So it's a very closely connected disease, closely interlinked. So we have to manage both the conditions to ensure that we give the best care for the patient.
Thank you, sir. This is my final question to you. We know that type 2 diabetes are commonly associated with obesity, which is commonly known as diabeticity. But a lot of South Indian diabetic patients are lean and thin. So how you explain this leanness with type 2 diabetes in South Asian context?
Right. In fact, any patient with diabetes type 2 should be, especially in the presence of adiposity, we have to manage this patient as diabesity. This is a schematic representation of the pathology of diabesity. You can see adipocyte injury from insulin resistance and worsening adipocyte dysfunction from abdominal adiposity is the key factor in causing a lot of chemicals which increase the insulin resistance and worsening of the diabetes and prediabetes state. So this is again coupled with adverse eating habits, which can worsen the insulin resistance. The problem with the gut microbiome, the abnormal gut microbiome can produce a lot of humoral factors, which results in worsening of the adiposity. Unfortunately, when we consider obesity with the criteria of BMI. BMI is not always a very good measure of obesity. As you can see from this figure, a person with good muscle mass may have higher BMI, but a person with low muscle mass or sarcopenia with abdominal adiposity may have prediabetes or diabetes state, but they have poor metabolic health. So BMI is not always a good definition for consideration of diabetes as well as pre-diabetic state. Anyone with abdominal adiposity in the anteroid distribution of adiposity, that's the case with most of the Asian countries with significant abdominal adiposity, but with normal body weight or normal BMI, may have worse insulin resistance and diabetes plus pre-diabetic state. Whereas if it is a gynecoid obesity, like pear-shaped fat distribution, as you can see from this picture, subcutaneous fat distribution may not have that much of problem, whereas visceral fat distribution with adipocyte-based insulin resistance, hepatic fat deposition, and visceral fat deposition in various tissues will worsen the diabetes. So we have to be mindful. It's not the body mass index or the body weight criterion we have to use. We have to use the abdominal adiposity as a criteria for managing these patients with lean prediabetes, diabetes, and even lean fatty liver disease. That's my take on that particular question.
And thank you so much, sir, Dr. Joseph Papasan, for your wonderful presentation and nice discussion. And that's all from the session of Ideation for Innovative Research. Now we'll move to Dayakshay for continuation of the next session.
Thank you.